All right. So Sainath basically explained to us the clinical features of pancreatitis. Now, what is important for us to understand is pancreatitis is not a um, pancreatitis was is not a disease that was initially treated by intensive care. Okay, way back 20-25 years back, pancreatitis was a treatment that was done by gastroenterologists. At that time, intensive care fraternity was not very strong. Nor did they understand the importance. There were no degrees, there was no DM, there was nothing like that. And there were no diplomas in critical care. So the gastroenterologists used to actually, that was the domain of the gastroenterologists. And as you know that there is nothing that they can do here, and it is left onto the intensive care to manage it. It's a very long kind of a disease. That is why slowly the intensive care fraternity took up pancreatitis, and since then pancreatitis is a acute disease of intensive care, and intensive care has to look after pancreatitis more than the gastroenterologist. Gastroenterologist role is very minimal in pancreatitis. Understand this. It is a pure disease of intensive care, which because of the nature of the disease, there are so many questions that can be asked in this disease that this is a sure shot question, 90% question in your exams. Pancreatitis. Okay, it's a disease that might come in the exam. So the first point that I would like to stress on is, how do you diagnose pancreatitis? Till now, he did talk about symptoms, he talked about features, but if you ask me how can you diagnose pancreatitis, there are three features, of which two features should be present. Okay, which are the three features? The three main features are a boring abdominal pain, characteristic of pancreatitis. The second thing is the lipase levels more than 3, and the third is a CT or a imaging finding or an ultrasound finding of pancreatitis. Out of these three, two should be present. If two are present, then this is called as pancreatitis or severe acute this is called as acute pancreatitis. Clear on this? So what are the three features? The three features are presence of lipase more than 3 times normal. Lipase, I'm not talking of amylase, I'm calling of only lipase 3 times normal. The presence of a characteristic abdominal pain. Sainath mentioned a lot of other features, Cullen sign, Gray Turner sign, nausea, vomiting. But what we are talking, abdominal pain, a characteristic abdominal pain, not even tenderness. Characteristic abdominal pain that exists for these patients. And the third thing is a CT or an imaging finding. It could be ultrasound, could be a CT, or could be an X-ray that actually talks about, that actually tells you about pancreatitis. So these are three features, of which even if two is present, this is called as severe acute pancreatitis. Now let's go to the pain. The pain part of the story is very important. Since the diagnosis hinges on just three features, there are these three features you should understand completely well. So the first thing was pain. Now this pain is a characteristic dull ache. It is not a pain that comes and goes. It's a dull, boring pain that remains in the epigastrium and may be there radiating to the back. This is called as the characteristic pain of pancreatitis. Okay, you can't have a pain that comes and goes, comes and goes, comes and goes. That is not the characteristic pain. The characteristic pain is a dull, boring ache that remains in the abdomen, mostly in the epigastric region, that radiates to the back. That is the pancreatitis pain that we are talking about. Clear on this? That is the pain. Okay. Now when we talk about lipase levels is a very sensitive, very sensitive enzyme. If the lipase levels are more than 3 times normal, then only we call it as pancreatitis. The sensitivity of this is 90%. So the chances of you picking up are very high. So lipase should be more than 3 times. Why is it more than 3 times? Because if it is 2 times and 1 time, this is not pancreatitis. There are many other reasons why lipase will go up, of which one is just a duodenal ulcer, a intestinal obstruction, a gallstone pathology, all these, even renal failure, even a creatinine more than 3 or 4 or 2 or 3 will cause the lipase levels to go up. So you can't just look at lipase just being elevated. Lipase has to be elevated more than 3 times. That is when the sensitivity of lipase goes to 90%. That is when the sensitivity goes to 90%. Lipase levels. Am I clear on that? Lipase levels? Lipase levels. And the third thing that we talked about is an imaging finding. So if there is an imaging finding, incidentally you did a CT scan, you found something on the pancreas, that is the third point. But you don't need these 3 points. You need just 2 points. So characteristically, you just require a dull, ache, boring pain and a lipase more than 3 times normal to actually prove that this is pancreatitis. Clear? So when Sainath did talk about, so this is about the diagnosis or the definition of pancreatitis. When they have an organ failure of any nature, this is called as severe acute pancreatitis. Simple. So if there is an organ failure, that means if the lungs fail, that is PO2 less than 60, if the creatinine goes more than normal, all these are signs of organ failure. If there is an organ failure, this is called as severe acute pancreatitis. Clear on this? If there is an organ failure, so that is called as severe acute pancreatitis. So this increases the severity very badly. So when Sainath started, he did talk about a large number of scoring systems. He talked about bicep score, he talked about CT severity index, he talked about Ranson score. There are many score systems that he talked about. By far, the commonest, what is the problem with all these scoring systems? First of all, they have not been validated in large cohorts of patients. Most of these scoring systems, they have not been very, very validated, number one. Number two is the Ranson score was the oldest score ever created in 1970. The surgeon is even dead by now. His name was Arthur Ranson. He's dead by now. Okay, he's 1995. He died. I mean, he died 20 years back. And he created the score in 1970s when the systems were not very good. That is why you have PaO2. Now, if you realize just PaO2 is not an answer, because if you have an FiO2, the PaO2 will change. Are you understanding? So PaO2 is there. He looked at BUN, he looked at creatinine, and he looks at SGOT, LDH, and all these things. So this score is not validated, A, because of the fact that in the first place, you need to have it at 48 hours. You have to wait for 48 hours before you can say that this is acute pancreatitis or say the severity of pancreatitis. So in short, what could you use? So that doesn't mean the Ranson score is bad. So in the Ranson score, if the first 24 hours in the first at admission, there is a Ranson scoring where you look at WBC count, you look at age, you look at RB sugars, LDH and SGOT. These are the things that you look at admission. That will tell you that if the score is more than 2, then this patient probably requires ICU. So if the patient comes to an emergency and the age is more than 55 and WBC count is 16,000 plus he has got an SGOT that is 260, this means this patient requires ICU. At least it tells you that at admission. Okay, it tells you at admission. You may use it to find out whether the patient requires ICU, but this is just a scoring system. It is you who's going to decide that. You're looking at the patient, will decide with your clinical examination whether this patient requires the ICU or not. Okay, but this may help you to determine whether this patient may require an ICU. At 48 hours, what it does is it gives you mortality indicators. Mortality, it tells you what is going to be the mortality at 48 once you look at the Ranson score at 48 hours. But now you must understand that this scoring system was made in 1970, so it may overestimate mortality because we have come through a long way after that. Our resuscitation strategies have changed. Our definitions of organ failures have changed. Our PO2, FiO2, PO2 values have changed. Many things have changed here. Can you hear me? No. Back to what we were talking. Sainath, you can hear me?
Yes, sir, we can.
Okay. So going back to what we were talking, we were talking about Ranson score, right? So Ranson score was a very, very old scoring system, and so it can be used for admission, but you can't use it because you have to wait for 48 hours before you actually diagnose a case of severe acute pancreatitis. So that's a problem actually. That's definitely a problem, and that's why Ranson score is not a score that I would